very good topic today. And that is,
with some of the best in the space for this topic. Absolutely.
yeah, and that's in BRCA and the breast cancer in men, which, for me as a breast cancer survivor, I think of my sons. I have two older sons, and sometimes they don't want to say breast cancer, right? They want to call it something else, but it's not. It's what it is, right? And we want to always address these subjects and the ones that are maybe not as common or as comfortable to talk about. So tonight we are doing this one, Erin, and I'm really happy to have our guests today. They're fantastic.
I am too. They are really moving the needle in this space, and I think encouraging communication and talking with family about the importance of not only screening, but getting into the discussion about what treatment looks like and what does long-term medication look like and what does surgery look like. So it'll be a nice comprehensive discussion this evening.
Yeah, for sure.
Yep.
Then Erin, do you want to show our slide of our wonderful sponsors?
Absolutely.
Yeah, you'll see on our Zoom background, we can't do what we do without our sponsors of this education series. And we do 36 of these a year, at least 36, right? So Erin is charged with being the director of our education. And we couldn't make it happen without our presenting sponsors, West, Merck, and Daiichi Sankyo. And then additional support from GSK, Lilly, Gilead, and we have AbbVie now. So
all right, let's bring Dr. Maxwell up. So do you want to introduce her?
Are you doing Dr. Maxwell? I'm doing Dr. Zhang.
Sure. I am honored to introduce Dr. Maxwell. So let me share a little bit. Dr. Kara Maxwell, who, again, both of our speakers are really leaders in this space. So she is an assistant professor in the Department of Medicine, Division of Hematology Oncology, and the Department of Genetics at the University of Pennsylvania School of Medicine, and a staff physician at the Philadelphia Veterans Affairs Medical Center. Her clinical practice is in the area of cancer risk evaluation. At Penn Medicine, she is a regional referral expert for patients with the Lou-Fermeni syndrome, which is a rare cancer risk syndrome due to the TP53 gene mutation. She's also the director of Penn Medicine's Baxter Center for BRCA's Men and BRCA program, which focuses on clinical excellence, education, and research in cancers affecting men with BRCA1 and 2 mutations. So, like I said, a real leader in this space. We are so enthused to have Dr. Kara Maxwell joining us this evening, but she will also be joined by
Dr. Jennifer Zhang. There we go. Jump right in. Dr. Zhang is an assistant professor in the Division of Breast Surgery. She is also the co-director of the Breast Surgery Research Group and a member of the Men and BRCA Leadership Committee at the Baxter Center. Her laboratory focuses on delineating novel immunotherapeutical strategies for circumventing mechanisms of the immune evasion in breast cancer, with a particular emphasis on hormone receptor-positive breast cancer. Her research includes an investigation of the immune microenvironmental in male breast cancer with a goal of improving therapeutic responses in this patient population. So please join Erin and I in welcoming our guests tonight, Dr. Maxwell and Dr. Zhang.
Thank you so much for having us.
You got it.
Thank you so much. Well, it's a real honor to be speaking tonight, as a member of this group, and I hope having this as as an educational resource for, patients who may want to click on the link later. One of our goals within the Baxter Center, Men and BRCA Center, is not just to raise awareness for BRCA-related breast cancer, but just for male breast cancer in general. And so, really excited to be able to present tonight. Oh, great. Okay. So we are going to have a little bit of a genetics focus tonight, and please do interrupt me if you want to interrupt anything. But really, all the things that we're talking about outside of, maybe just the first little part about genetics is really applicable to all men who have been diagnosed with breast cancer. And, one of the things that I think I was so thrilled to see that Unite for Her is now Unite for Her, Him, and Them. When we're talking about men in BRCA, we are talking about individuals who are born male at birth. So sex at birth is identified as male. There are many, many, many issues that, I think also surround breast cancer in transgender men. That's not going to be a focus that we're talking about tonight. And we've already, put the plug into Erin and Sue's ear about also doing some work, with our transgender male colleague or patients. And so I just want to make sure that we sort of start with that caveat that we are talking about breast cancer in those born male sex at birth. Okay, so let's go to the first slide and put up a little bit of a genetics overview, because if you have anybody in your family who's been diagnosed with breast cancer as a man, or if you yourself is a man who have been diagnosed with breast cancer, the most important sort of first step in my mind, obviously not the most important first step for everybody's mind, but as a geneticist, is I want to make sure that people understand that they should get genetic testing. So really, our indications for genetic testing have really expanded in recent years. And so any, any man who has been diagnosed with breast cancer, and then just simply one family member who had a breast cancer, should think about genetic testing. And we'll talk about that a little bit more. But what are we even talking about with genetics? Let's just try to get on the same page when we think about that, because there's so many different technologies that are occurring. And when you have a diagnosis, when your loved one has a diagnosis, you're thinking about so many different tests that they're getting. When we're talking about genetic testing, what we're talking about are changes in your DNA. And when we think about just going back to basic biology, every one of our cells, is made up of a number of different components, which include our DNA made into chromosomes, as shown here on the left. And a mutation or a variant is any change in your DNA. And you can have changes that make no difference, that have no impact on your risk of disease, or you can have variants that actually do increase your risk of cancer or lots of other diseases. So let's go to the next slide. So why do we care about the BRCA gene specifically when we talk about breast cancer? Is because they're really one of the few syndromes that we know about that really increase the risk of male breast cancer. So breast cancer in men occurs in maybe about 1 in 1,000 men. And so this arrow, this little red arrow here, is meant to depict that the risk for breast cancer in men in the general population is exceedingly low. Like I said, about 1 in 1,000 men. But if you have an inherited mutation, if you're in a BRCA 1 or 2 family, that risk is elevated. So if we follow these curves, what these curves are looking at is what's your absolute risk of developing a breast cancer at the age of 30, 40, 50, 60, 70, 80, all the way through for both BRCA1 and BRCA2. And one of the things that's important to notice, the shaded bars just basically indicate the range at which that percentage could be, is that even for BRCA1, that risk of breast cancer might be around 1% by the time you turn 80. So most men who inherit a BRCA1 mutation will never have to deal with breast cancer. In BRCA2, the percentage is higher. It's about 5% chance of having breast cancer. But again, it's not as high of a chance as we talk about with women. But the point is that this is highly, highly elevated over the general population. And so it's one of the things we think about when we think about taking care of men from families with BRCA mutations. So let's go to the next slide. So going back again to that, who should get genetic testing? And hopefully this can serve as a resource beyond, just the male breast cancer, because our guidelines keep changing. And for all women diagnosed with breast cancer, we keep changing it too. So it's always good whenever I get a chance to talk, I like to remind any woman that might be listening who's had a breast cancer diagnosis that the guidelines have almost definitively changed on whether or not you yourself should get genetic testing, depending on when you were diagnosed. And the genes that you might have been tested for could also have changed. The technologies have changed. So this is always just my friendly public service reminder to all women diagnosed with breast cancer to go back and maybe think about, should I get updated genetic testing, or should I get it at all if I never had it before? But when we think about men, and as I already mentioned, any man with male breast cancer should get genetic testing. Again, you may have been diagnosed, you may have a father or a grandfather in your family who was never tested, but that is enough when we look at the family history side over here on the right. So BRCA 1 and 2, shows how this inheritance is what we call autosomal dominant. That means that if you yourself have a genetic change, your children have a 50% chance of inheriting it. So again, if there's more than one close relative, and this can be grandpa, like mom's father had breast cancer, we would think about testing you. So that's any male breast cancer, any ovarian, pancreas, or advanced prostate cancer in your family should think about genetic testing. And then just to round out the cancer diagnoses, I know this is a breast cancer talk, but again, if you've had other cancer diagnoses, many men should get genetic testing, for example, advanced prostate cancer or pancreatic cancer. So there's many questions always about who should get genetic testing. And so I always say, it's so complicated. Even my oncology colleagues can't keep it straight. So never feel that you're asking a silly question if you ask your provider if you think you should get tested. So we'll go on to the next slide. And this talks a little bit now about breast cancer in men and sort of about screening. And so again, if you happen to be from a family who has a genetic mutation, you yourself have one, or you're at risk for other family history, most breast cancers in men, we don't find a mutation. And so it might be that your father or grandfather had breast cancer and we don't know why. And so you may also be wanting to think about your own risk. So there's much debate currently in our field about if we should call male breast cancer, should we call it chest cancer, what should we call it? But the fact of the matter is that all men have breast tissue that develops similar to breast tissue in women, just not for the same purpose, so it doesn't become as developed. And as such, every man has a different amount of breast tissue. And I always tell men, it has nothing to do with your body weight. You can be a very skinny man and have a lot of breast tissue, or you can be a very large man and have very little breast tissue. So it really just matters that you feel comfortable talking about that and thinking about that part of your body, which many men, really don't think about in that way. So when we think about examining a male for their breast tissue, we really want to focus on the nipple area. Dr. Zhang, I think, will talk a little bit about that most breast cancers in men do develop under the nipple, but we do want to make sure that we are feeling the rest of the chest wall area, including the lymph nodes that go up into the underarms. So when breast cancer spreads, it goes to the underarm first. And so some men do present with breast cancer in that way. They find a lump in their underarm. It isn't going away. It's really hard. And they say they go in for that. And that's how they end up being diagnosed with breast cancer. Self-exam is a big topic. Should everyone be doing self-exam? How often they should be doing self-exam? One easy place when you take care of genetic carriers like mine is that if you have a family history of male breast cancer, or are a genetic carrier yourself, that's an easy one. Once a month, a self-exam is a good thing to do. Most men do find their own breast cancers versus having it found, say, by a provider. Men can also do mammograms, and I love that I found a picture of a man getting a mammogram from an Army website. One of the things, I work at the Philadelphia VA, and I'm very involved with, a number of our veterans who really want to sort of break down some of those barriers in the very macho male population. Like, look, men get breast cancer too. Who knows what kind of exposure some of our more recent veterans, in the Iraq and Afghanistan conflicts might have been exposed to that may increase their risk. So, this is an example of actually doing screening versus with a mammogram versus by self-exam or by feeling by a doctor, by physical exam by a doctor. So men will say to me, I don't have enough tissue to get a mammogram. You do, everyone does. And so, it's the technology is so advanced nowadays. Mammograms are so great. They're really, really good at finding cancers in men and finding cancers very, very early. So this is still a decision. Not all of genetic carriers decide to do mammograms, but some men do. There's been big pushes at places like Penn Medicine to get rid of the pink gowns, to get rid of the pink everywhere within, the mammogram suite, so that men feel comfortable going down and saying, yeah, I'm getting a mammogram, and so but those are still obviously a lot of barriers that we need to, break down to make men feel more comfortable getting this. But it is something that I think is changing. And then, of course, if you are If you do have a mass that's been felt, that would be the first step, is that your doctor would send you to get a mammogram to work that up work that up and figure out what to do next. So we can go to the next slide. And we'll turn it over to Dr. Zhang. So for if, unfortunately a man is diagnosed with breast cancer, their first stop is typically a surgeon. And so I'm going to turn it over to my colleague, Dr. Zhang, to talk about the surgery, unless anybody on the call has any questions about the genetics now.
Okay, great. Thank you so much, Kara. And just as Dr. Maxwell alluded to, most of these cancers that when I see a male present to my clinic with a new diagnosis of breast cancer, usually the story is that they have felt something, or maybe their wife or their partner has felt something. And then further workup was done because of that. Because as Dr. Maxwell mentioned, in carriers, there is a joint decision between the physician and the patient to decide about whether or not they would like to pursue screening mammograms. But in general, in males that are not known carriers, we don't have such a decision, and mammograms are not being done. And so often actually male breast cancers can present at a slightly higher stage or a little bit of a larger tumor than female breast cancers, just because by the time they become what we call palpable, where they're able to be felt by someone, it is a little bit larger compared to the female breast cancers, which can be caught at a smaller or earlier stage. Typically, the male breast cancers, again, as Dr. Maxwell had alluded to, they present mostly under the nipple in that central area, just because sort of the conglomeration of all the ductal tissue in the breast, they kind of are at the greatest percentile or the highest density right under the nipple. That's where the greatest amount of breast tissue is. And so in terms of the surgery itself, actually, we treat males very similarly to females who have breast cancer in terms of the type of surgery that they are candidates for. And for both males and females, generally patients have the decision between mastectomy, which means removal of all of the breast tissue, and leaving the skin envelope to sort of close over so that you don't have a big, opening in your chest wall. Or you have the option of what we call lumpectomy or partial mastectomy. Those are generally the two terms that you'll hear, but it's leaving the entire breast intact, but you're going to remove the actual tumor itself and some surrounding normal tissue to make sure that you don't leave any abnormal cells behind. And so typically that would be done, a lumpectomy would be done through a relatively small incision, maybe 3 to 4 centimeters. You go and we remove the tumor. And the pathologist will test it to make sure that there's no residual leftover tumor at the edges. So let's just talk through a little bit mastectomy first. So that's the removal of the entire breast. Usually with a mastectomy, the nipple and the areola are removed. They are not preserved at the time of surgery for a number of reasons. One, usually because the tumor is relatively close to the nipple. We want to make sure there's no tumor left behind. And the second is usually when we do remove tissue, there's some redundant skin because you do still have some breast tissue. Sort of, if you think about it, it's kind of like you have a bag and you're removing something inside. Once the thing inside is gone, the bag will wrinkle somewhat. And so it's, unless you fill that defect with something, whether it's an implant or your own tissue, you have kind of a potential space that may either fill with fluid or it sort of wrinkles. And, for cosmetic reasons, generally, we do remove the nipple as well. And the incision is usually what we call a transverse incision, which is just horizontal, which you can see. I don't think my pointer works, but you can see that in the variety of photos here. And of course, depending on is sort of the opposite breast, often people will have an asymmetry, right? And so one breast will be flat and the other breast will maybe have somewhat of a projection. It really depends on the patient and the body habitus. And so so that's basically what it is with mastectomy. And the recovery is about 4 to 6 weeks. It's a little bit longer than lumpectomy. So we move over to what the lumpectomy recovery is. Generally, lumpectomy is a day surgery. And it's a very short recovery. It's about a 2-week recovery. It's really just a local type of surgery. So how do we typically help people choose between mastectomy or lumpectomy? It really depends, I think, on sort of your goals in terms of what the cosmetic outcome are. If you want to avoid having, somewhat of a bigger surgery, if there are other medical problems at play, which maybe, you have a higher risk of bleeding, you are not able to undergo anesthesia for a long period of time, because sometimes lumpectomies we can do under what we call local anesthesia, where you're not completely asleep. So really depending on all of those things, I will have to say that, based on my experience as well as of all the data that we know of male patients with breast cancer, 75%, so I see the majority of patients will choose mastectomy. Mostly because with lumpectomy, really it would be recommended, just like it would be in females, that you get radiation afterwards, because the rest of the breast still needs to be protected, and the risk of recurrence or the cancer coming back increases, is higher if you don't have radiation. And so, if you don't mind having the breast tissue removed and the nipple removed, then that's a potential. If the tumor is small, you may be able to avoid radiation. Um, with mastectomy, depending on whether or not, as Dr. Maxwell mentioned, if the lymph nodes are involved, you may still need radiation, but many patients after mastectomy do not need radiation. So that sort of brings me to the second part of the surgery, is what we call axillary or armpit lymph node surgery. So there's a conglomerate of lymph nodes under your armpit, and breast cancer spreads first generally to those lymph nodes. And regardless of whether you have a mastectomy or a lumpectomy, those lymph nodes have to be sampled. And by sampled, I mean actually physically removed at the time of surgery. And I won't get into the weeds on this, but depending on sort of the stage of the cancer, we either just do a small sampling, removing, maybe on average of 3 lymph nodes, for the pathologist to test and see if there's cancer there, or we remove all of the lymph nodes. So that really just depends on the presentation, but some type of lymph node surgery will be performed at the time of the breast surgery. In terms of risk of the cancer coming back locally within the breast, we don't have as good data in male breast cancer compared to female breast cancer, but from a combination of clinical trial data and retrospective data, meaning where patients are not really matched exactly perfectly like you are in a randomized controlled trial, we do think that roughly it is about the same between getting lumpectomy with radiation compared to removing the entire breast with mastectomy. And that's probably about 5 to 10%. In patients who maybe are not happy with the way the breast looks, or they know before the surgery that they do want some type of reconstruction with plastic surgery, there are options. So that's one thing I did want to let people know. Sometimes they can be a little bit more limited compared to women, because the pre-made implants that the device companies make are generally larger. But sometimes you can make smaller implants, custom implants, or have tissue transfer type of surgery, where they take your own tissue and they fill the defect, the space where the old breast tissue used to be, with tissue. Most of the time it's taken from your back, from a muscle in your back called the latissimus muscle, to fill that space, to basically rotate it towards the front of the chest. There's also actually nipple reconstruction that can be done. More commonly is what we do nipple tattooing. And actually, a lot of women do nipple tattooing as well. And the tattoo artists are very, very good. They make these 3D nipples. I wish I had a picture of it to show you, but it looks very good. And so these are just some options sort of to keep in mind also. And in terms of surveillance, right? What do you do afterwards about taking a look at the breast where you had cancer, as well as the other breast? So typically, in patients who are not carriers of a BRCA mutation, in the other breast, we don't typically, say you have to have a mammogram every year. That's really a discussion that you can have with your doctor. For patients who are carriers, often we do recommend, the guidelines really do recommend that you can, get a mammogram on the other side, but the risk is actually still quite low. So if you didn't want to do it, that would also be fine. The only place where I would recommend a mammogram is if you get a lumpectomy. On the side where you had the cancer after the lumpectomy, you should continue to get a mammogram every year, just because there still is that risk of the cancer coming back in that breast. I think that's all I had in terms of the surgery. Does anyone have any questions about that?
So while people are thinking about questions or coming off mute, before we can go to that one, I actually wanted to leave Dr. Zhang's surgery slide up. So this is so informative, and thank you, Dr. Zhang, so much. One thing that's coming up just in general is as more women consider, contralateral prophylactic mastectomy, we've been getting this question in men as well, genetic carriers and non-genetic carriers. And the risk is so low that, we haven't traditionally talked about, contralateral prophylactic mastectomy. But one of the things that I think is tough is when a man tells me, I just hate the way I look, and I really want to look symmetrical again. I don't like to have my shirt off. Can you talk, you mentioned it, but can you talk about both of those pieces? One is the contralateral prophylactic mastectomy at the time of a diagnosis, and then maybe just allude a little bit more to the, instead of trying to flatten both sides out, maybe a plastics option might be better. If you don't mind providing your opinion on that.
Yeah, no, of course. I think definitely it's a great question. And again, we don't have a lot of data right in this space, but there was a large review basically of about 10,000 male breast cancer patients. In that review, actually about 5% of those patients had gotten a contralateral prophylactic mastectomy. Now, I don't know if they were carriers or not, but it certainly is happening, right? And so it is important to talk about that. So I think I would say the correlate is that in women, even in women who have very low risk of contralateral breast cancer, we certainly offer or, do contralateral prophylactic mastectomy when the issue is symmetry, right? And so sometimes women just want both of their breasts to look the same, and for whatever reason, we can't achieve it with, a breast reduction or different kinds of plastic surgical techniques. And I think if, symmetry is very important, I think that's, certainly one reason to consider it. If there is really a very, very strong, fear of having another breast cancer, right? If you're a carrier or you don't want to do mammograms or there's some other, reason, we certainly, again, another reason to consider it. I would just say,
go ahead.
oh, sorry. No, I was just going to say sort of the counterpoint from my standpoint is, as a surgeon, we do also see great successes, but also complications, right? And you always remember, even if there aren't a lot of complications, you always remember the complications. And those are the things that haunt you. And I do want, everyone, when we talk about things that maybe we don't have to do in terms of the actual cancer itself, to consider, listen, there are also things that are downsides about removing the other breast, which is, a little bit of more recovery, right? The procedure itself is muscle sparing, meaning that we're not cutting into the pectoralis muscle, but we certainly peel the breast, including the fascia, which is the small thin layer of connective tissue off the pectoralis. And so some people actually can have a little bit of a, I wouldn't say a limitation, but there may be some mobility type of issues, especially around sort of the front of the chest as well as the shoulder, especially in patients who already maybe have some baseline mobility type of issues. That's something to consider. When we remove the breast with the mastectomy, it also actually severs all the microscopic nerves that go up into the skin. And so that whole chest wall, you'll feel numb. And so somebody hugs you, you don't really feel that sensation anymore. And so that actually isn't something to be taken lightly. And also a very small percentage of patients, probably 5% or less, have what we call post-mastectomy pain syndrome, which I think is some type of neuropathic pain. And so those are all things to consider also, is that it's not without any complications. So in general, I would say that if you have a pretty advanced cancer where we know that you're going to need chemotherapy, you're going to need radiation afterwards, it may make sense to just do the side of the cancer, to have that surgery done, get through sort of the life-saving cancer treating, surgery. And if afterwards you're still not happy with the look, there's some things that maybe can be done, like liposuction, or we can do a prophylactic mastectomy at that time. And often I recommend that to my female patients also. And so it doesn't have to be a one and done, right? You have options down.
No, thank you so much for saying that way. I think, we're definitely in a space right now where there's so much, bilateral mastectomy happening, and men are hearing this too now. And just, it's so important to remind people, all of the potential surgical complications, and that, even in genetic carriers, even in women, we're not necessarily recommending that for everyone. And so it's just, again, for anyone listening later on, it's such an important conversation to have with, professionals that really understand the risks, before sort of doing a larger surgery than you may need, and knowing that there's other options. So thank you for bringing that part up. That's really helpful. I don't know if other people have questions before I finish up with the medical treatment side.
No, I think we're looking good. I actually just had one question. And I think I know the answer, but if someone is diagnosed with breast cancer under 50, but they're not BRCA 1 or 2 positive, do they still have to have their children get genetically tested as well if they have boys? Or
It's such a good question. So, the person who had the cancer is always the best testing candidate. All the genes that we talk about in genetics of cancer don't skip a generation. So that's always one of those things like, oh, it's one of those syndromes that skip a generation. These are all what we call autosomal dominant. So if you are negative, you couldn't pass on a risk that we know about. What I always caveat is that only means what we know about right now. So if you're a woman who is under 50 and was negative, or a man who was negative, in 2024, we may not need to test we will not need to test your children. But your children may eventually, genetics is going to change remarkably fast in the next 5 to 10 years. And so there are many people who come back to us and say, look, my mom did testing, in 2010, what's new? And we say, oh, there's actually a lot that's new, so she may have been negative then, but we may consider testing you now. But I think the most important caveat is when you're going through this, if you're negative, you don't need to worry about testing your children right now. And that was a sufficient test. There's so many different more parts I can go into that, Sue, but was that clear?
No, that's perfect. And we actually have 2 questions with their hands up. Guy, I was going to let you go first. I saw you had your hand up. You want to unmute?
Yeah, so I appreciate you folks, that information is very important to me. I'm a breast cancer survivor myself. I had my breast removed in February. So I was diagnosed in 2017 and went to the whole chemo. And only when I do my radiation that my surgeon decided to say, hey, you might have to go and have surgery. I just thought I was going to do radiation, and it wasn't something that I was looking forward to, but I'm glad I went through it. So it's all about the information. I mean, I kind of was just in denial for a long time. I found a lump in 2000.
Mm-hmm.
And for the first 15 years, I didn't tell anybody. I was just too embarrassed to say anything. I think that's what males go through. The big, macho kind of thing. They don't want to open up themselves like that. So I kind of struggled for a long time. But obviously, since I had my breast removed, it's even more important to me now that I think males should be able to test, because I think that's why the numbers is so low.
Yes.
Because males is not stepping up. So they're just too proud of doing it. So that's why it's like, 1 out of 800 men that gets diagnosed like that, because the numbers is alarming. But my question is it because male breast cancer patients, is it because the estrogen is higher than the testosterone level? I mean, that's kind of what I was just kind of thinking about. I mean, is that what's happening with males that is diagnosed? Is it because their estrogen levels is much higher than the normal?
So it's a really excellent question, Mr. Nakoa. And I just have to say first, thank you for sharing your story and being open, because that's what we need. You know, we just need men saying, you know, and going out there and being like, yes, I was scared, but, you know, I did this and it was so important. So thank you for sharing that. It was so really, really touching to me. As far as why men get breast cancer, there is certainly the situation that men who have Klinefelter syndrome, which is you have two X chromosomes and a Y chromosome, these men do often have slightly higher estrogen levels, that those men are at risk for breast cancer. However, in the general male breast cancer population, it does not seem to be solely related to estrogen levels. And for especially in patients with a genetic risk, there seems to be no relationship. And I think that's important, because I think that many men who are diagnosed with breast cancer, they could feel embarrassment of like, oh, my testosterone's low, or my estrogen's too high, or that sort of thing. And that likely had nothing to do with it. I don't know, Dr. Zhang, if you want to add on anything, but you know, I think the reasons that men get breast cancer are still relatively unclear. And one of the really great work that we're doing at the Perelman and BRCA Center, you know, by Dr. Zhang, is to look at the immunological components. Are there any sort of immune issues that actually lead to breast cancer development in men that could have nothing to do with any sort of hormonal levels whatsoever? So, you know, I think it's important, obviously, to balance these things. And for men who have syndromes where, you know, they're like I said, like Klinefelter's, to know that that's a relationship, but that also not to sort of get hung up that it's like, oh, it was estrogen related.
Yeah, no,
Appreciate that.
exactly. You know, and this is probably, you know, take what I say with a grain of salt, because this is sort of, as Dr. Maxwell had said, I'm interested in exploring this topic in terms of better understanding how our immune system contributes to the development of male breast cancer. But these are just theories that I have, right? And so I think one theory is sort of what part does the immune system play? Because we know that males compared to females in general have a higher risk of cancer, not just breast cancer, but any kind of cancer. And we know how important the immune system is in terms of cancer surveillance. So your immune system is actually able to kill off several cancers in your lifetime, right? That you never know that you've had because your immune system has just wiped it out. And so in general, the male immune system tends to be a little bit less aggressive or immunologically activated compared to females. And if you have any female relatives with autoimmune diseases, you know, you may have observed already that women tend to get more autoimmune diseases than males, probably for that same reason, right? It's the other side of the coin where the immune system is highly activated in women. And so you know, certainly that could be a potential explanation. And, you know, we are trying to look further into this in the next year or two. So hopefully we have some answers soon. It's not so
I
simple as,
appreciate you
you know,
guys.
one or two. Yeah. Mhm.
I appreciate you guys sharing. I mean, definitely more information, power is knowledge to me. So, and then just to get back on the genetic testing, I never had it done. I requested when I had my breast removed to have it genetically done, but I was living in Ohio about 5 years ago. So my daughter has high blood pressure.
Uh-huh.
And so she was kind of talking to her doctor. She's got high blood pressure. She probably got it from her dad. And then the doctor asked her, oh, okay, what was going on? Oh, my dad was tested. He had breast cancer. So they automatically made her take the genetic testing. So she's only 36 now. She's going to be 37 this year, but she came back and it was negative.
Oh,
It was
good.
negative. So my whole question to that is, since she was negative and I only had one daughter, should I still go and get it done, or
Oh, it's such
because
a,
I'm
it's
not
like,
planning on having any more kids. I'm like 200 years old now. I mean, you know.
but it's like we planted you as a perfect person. You don't know how many times we hear that men do genetic testing for their daughters. Period. End of story. And it's beautiful and wonderful, and I love it. But it is important for you as well. It's possible the reason why you weren't tested when you were diagnosed is that Medicare took a long time insurance companies, Medicaid, all of them took a very long time to get on board. And so even though the guidelines were to do genetic testing for all men for at least 10 years now, many insurance companies did not cover it. And because of that, many breast surgeons, said, it's just, I'm not going to get it covered. I'm not going to add this to this poor guy's plate right now. He's got advanced cancer. He's going to need chemo, et cetera, et cetera. And it just goes under the radar. And Medicare, though, now does cover men. So I highly, strongly encourage you. You can go to basser.org. I'm sure Unite for Her has some sites that can get you a place to do genetic testing, because you could still be positive and your daughter's negative. And that is very important information for her and you, because number one, it would show her she's negative for whatever you had, if you had something, right? That's number one. But number two, for you, it could affect your screening for other cancers. And so, like I said, I know that many people say exactly, you have no idea how many men have told me, I'm not having any more kids. My daughter's negative. I'm not testing. And I'm like, no, I need to test you. Because it could affect you as well. I hope that I didn't sound too patronizing right now, but there's some of that we'd like to make sure we understand, because you have no idea how many men tell me they were diagnosed as late as 2019 and they didn't get genetic testing because somebody told them their insurance wouldn't cover it.
Yeah, thank you. And thank you, Guy, for sharing. I have a story of our offices, here in Westchester, and we get mail delivered all the time from FedEx and UPS, and our FedEx deliverer, a male, came up and he goes, I had no idea that you guys were breast and ovarian cancer. I had no idea you did that. He goes, I'm a breast cancer survivor.
Oh.
And we almost fell over. We couldn't believe, like, all these years he's been delivering. And I was so glad he just came out. So I agree with you, Guy. You just have to keep having the conversation. And I feel like we need to interview you and put you on our social media so that people are actually seeing males talk about it in a way that is just so natural and thoughtful and really respectful of the conversation that needs to be said. Maria, you have a question. I see your hands up. You've been very patient.
That's okay. Thank you very much. And it's great information. So I was diagnosed in 2021 with breast cancer, and my genetic testing was negative. However, there's a strong history of prostate cancer in my family. My father had advanced prostate cancer, passed away. My brother had prostate cancer, and I have an uncle on both sides of my paternal and maternal. So I worry about my sons as far as should they get genetic testing? Because I didn't know until I was diagnosed that prostate and breast cancer were like not related, but in that same line.
No, Marie, it's such a good question. And, I always remind people that, we only know the genetic cause of cancer in families, at best 20 to 25% of the time. We still know so little. And, I'm sure we're certain there's other factors, shared exposures, et cetera, but we also don't know the genetics in some families with very, very strong histories. So one of the things I'll say is that depending on what you were tested for, it's likely you were tested for all of the genes that also affect prostate cancer risk, but there are a couple that you might not have been tested for. And we would just encourage your brother, if I don't know if your brother is still living, but if your brother is still living,
he is.
to consider testing himself. The other thing we'll see is a phenomenon we call a phenocopy, which is you have a BRCA family and one person, maybe say two sisters have breast cancer. One's positive, one's negative. 12% of women get breast cancer. So you can easily get breast cancer or prostate cancer and be in a BRCA family and be negative. So there's also that piece that you could be negative, but your brother and father and, other male relatives who've had prostate cancer are positive. So that's also something. And then with, you know, again, as I'm saying, you know, men can benefit from genetic testing. Now, say though that your brother goes out, he's negative as well, and we don't understand the risk for cancer in your family. I strongly tell boys of, particularly for them, it's going to be mom, right, who their history is through. And a lot of primary care doctors really don't like to do PSA screening right now. The United States Preventive Task Force Service actually recommends against prostate cancer screening, except in genetic carriers, African-American men, and people with quote unquote strong family histories. And a lot of times people think, oh, it's mom's side, it doesn't matter, which is obviously a misconception, but I've seen even, you know, primary care doctors say that. So I tell people to go in, you know, so sons of families like this with strong prostate cancer, 10 years younger than the youngest diagnosis, or at least by age 40 is when you should start doing PSA screening. So even regardless of the genetic testing outcome, your boys should think about, you know, doing PSA screening, because again, where you live, what part of the world you're in, the country that you're in, and the world, I guess, you may or may not have access to PSA screening. And we see a lot of these really strong family histories. Prostate cancer is the most inherited cancer of all of them, actually. And for most of the families, we don't actually know the cause.
Okay, thank you. My sons do get oh my gosh,
testing.
the PSA testing. Yeah,
Good.
so
Good.
which is good, but
yeah.
Okay,
But
thank you so much.
Of course.
Erin, I didn't see anybody else. Did you?
I did not, but I do have a question about mammograms before we move on, because listening to you, Dr. Maxwell, and mammograms and discussion around screening, it made me think of the conversation that we hear of mammograms in women and dense breast tissue or very dense breast tissue, and the need for additional screening. And I just wondered if that was the case in males as well.
Oh, it's like, you know, we have planted you in your questions. And so this is another thing that we're really interested in within the Bachelor Men in BRCA program. And so we have a wonderful pre-medical student, very intelligent, Maliha Taib, who's been working with Caitlin Orr, who's on the call right now, to actually review this, because we frankly didn't know. We didn't know, like, what is the density of men's breasts? Like, are we seeing differences in the density in men who were diagnosed versus not? And some of that's been looked at in non-genetic carriers, but not in the genetic population. And so we haven't really seen any suggestion. And Dr. Zhang should talk about sort of the general population as well. But certainly in male carriers, you know, every single man diagnosed with a breast cancer, we're on the 2 low density ratings. So if you know about breast density, the highest is category D, or extremely dense, and C is heterogeneously dense. None of the men had those density ratings, but they still were diagnosed with breast cancer. And in general, mammograms work really well in men. Dr. Zhang, do you want to comment on anything from your clinical experience on that?
Yeah, typically I think an MRI is not usually needed, and the guidelines don't necessarily recommend MRIs like they do for women, just because of what Dr. Maxwell said. I mean, the males don't have very dense breasts, and there's not a lot of, breast tissue in general. The tissue is really concentrated sort of in the central breast. But I will say that, MRI, I think, is a tool more and more for us for problem solving, right?
Yes. Yeah.
Maybe somebody comes in with gynecomastia, which is just like a very natural, normal enlargement of the breast, but you're feeling something there, you're not quite sure what it is, mammogram's not resolving your issue. Or similarly, someone's coming in with nipple discharge, you don't have an answer from mammogram or ultrasound. I think we sort of think of MRI as more a problem solving type of tool rather than use for screening, I think, in males.
Great, thank you.
So I'm sure go ahead.
No, I was thinking, Dr. Maxwell, the only comment I had too, and I'm so glad you guys brought it up, is the nipple tattooing, because I just know me as a breast cancer survivor, I did not get that done until 9.5 years later. And and even waited to get reconstructed for 4.5 years. And it changed the way I viewed in the mirror. I couldn't get over it. It took the scar attention away when you have something else to look at. And I just can see that with the males, that I hope it becomes very normal for them to get that done, because I'm looking at these photos and I don't know if have any with, men getting nipple tattooing, but it's just, it could almost look very similar. And, I
100%.
know I'm grateful because it almost was like, oh, I haven't seen that in 10 years, and it made a difference. It made such a big difference. Yeah.
So it's my favorite thing to do with med students. I sort of test them whether or not the patient had reconstruction or not. And you don't know how many times the student will say, oh no, that's natural. And I'll say, no, that's actually a nipple tattoo, right? So, I mean, it is so true that they're so good. And, and I just had, a very moving conversation with a male veteran who is in his 70s and just really just doesn't like the way he looks, right? And so it just shouldn't matter your age or your body type or whatever it is, you should feel comfortable when you look in the mirror. And like you said, that's the real component to the nipple tattooing that can make a big difference. So I'm glad, Dr. Zhang, you brought it up, but I think that, it's definitely important to think about.
Yeah, and nipple sparing, like there's just so many advances in surgeries that it just makes me hopeful that that will also come to the male breast cancer community as well.
I had my girlfriend, I was walking around with my shirt off, walking around because I live in Hawaii. So I want to get my color back, right? So I'm walking around because I'm white like a ghost. And my girlfriend's like, why you don't have no shirt on? Like, aren't you ashamed? I'm like, no, I want people to see me. I want people to see me knowing that, hey, this guy got something and he got it going on and he's not afraid to hide it. So I thought about doing a tattoo too, like maybe some warrior spirit or something. But
yes, I love that idea too. I just think that's a beautiful idea.
Yeah, I mean, you don't have to get defeated because you was diagnosed. That's the way I look at it. I'm so blessed to be alive still today, to be able to actually share my story, because I think, from finding the lump in 2000 and actually living with it now, it's 2024. It's totally a blessing where I get to share it. So I'm heavily involved with the Pacific Cancer Foundation of Maui. I'm going to go back to college. I'm 61 years old. I'm going to back to college to study male health.
Oh, wonderful.
I'm a caseworker because I think that's what most of our cancer group has. So tonight we have a cancer group meeting with some patients. And I think a lot of them is they lose connection with the people that's involved in their lives, their family or whatever. They can't seem to fit in. And I think that's a huge thing. And accepting the fact that you're going through this hard time. And I'm not just talking about me as a male breast cancer person. I'm just talking overall, all of it, straight across the board, because they all have the same dynamics, the same struggles. So it's scary and it's lonely and stuff like that. But I think this is about, what you guys are sharing. I think it's powerful and I appreciate you guys sharing. So I'm so glad to be here.
Thank you. Be careful, Guy. I'm going to sign you up for our fashion show. Careful. I'm loving your voice. So we do this fashion show. We do them virtually.
I always like to get away with the fact that I'm always shy, but I think I'm more afraid of not saying anything instead of being shy. So that's kind of what pulls me out. So, if it's what you guys need, I'll be honored to be here. It's
so
huge.
Good.
It's huge.
I love that quote, Guy. Yep. I know we did not plan him, did we? Nope.
No. Amazing and just really helpful. Did you want, I could finish up with the sort of the medical treatment side, but we could also just continue the discussion, whatever works for you guys.
Well, I think we're at the hour, so I don't know if you have, if you could just summarize. It's such a good segment. I'd love for you to summarize it. Do you agree, Erin?
Yeah, absolutely. I'd love to hear it.
And I don't think we really even need the slides, to be honest, because, if people were, when you were listening to Dr. Zhang, the important thing here, this slide shows it, is that male breast cancer is treated the same as female breast cancer, and I think that's important to recognize that when you're diagnosed, you might have a possibility of needing radiation, chemotherapy, and hormone therapy. One of the things that's definitely brought up a lot is that men haven't been part of the clinical trials often prove the efficacy of many of these treatments. But in fact, for some things they really have. So for example, tamoxifen, which is often used after a breast cancer treatment in men with ER-positive breast cancer. And this gets back, this is a hormonal treatment. So don't get me wrong. It's not that estrogen isn't playing a role. And so suppressing any estrogen that a man has, is important and has been shown to reduce the risk of recurrence, in men the same way as it does in women. That said, it doesn't mean that there aren't a lot more things that are needed. Men with breast cancer are often not in, most of the clinical trials. But at this point in time, our medical side treatment, making the decisions about chemotherapy and hormone therapy are the same, indications as in men. As in women. So that's pretty much the nutshell. There's not really anything specific to talk about, but just to know that, those things are important, but also trying to encourage more male breast cancer trials. I think, as we move forward into the era of, big data and the potential to do trials that are what we call these like real world trials, where you use data to sort of design analyses that can help you, or just real bona fide clinical trials are important. So that's my last sort of piece. Always when you're diagnosed with something, with a cancer, NCCN, our guideline, always says that a clinical trial is an important piece of a cancer patient's journey, even if you don't contribute to or to participate in one, just even knowing that that's out there. So yeah, that was my little spiel on the medical side treatment.
Wonderful.
Can I just chime in here on quick?
Yeah.
I'm sorry to keep on talking, but so I took the tamoxifen, and for the longest time we've been taking the tamoxifen, but my oncologist told me, hey, let's switch it to the women's cancer medicine. We're going to have a special clearance to do that. And I think it's called letrozole.
Letrozole, yep. Mm-hmm.
So I'm taking that, it reversed everything. So it actually went the other way. So I was so thankful that Dr. Okazaki at the time did that. But yeah, since he was talking about tamoxifen, in my case, it went the other way.
Yeah.
So I think that's what it is.
Yeah, and we can have, and definitely further on, we could always have conversations about none of these medications are easy to take for anyone. And, happy to talk about, that at a future time. But I just thank you for putting up our Men in BRCA program slide. That's a QR code. There's these are the wonderful folks that I get to work with. We have experts in gastroenterology and urology as well. And so if you want any more information about some of the genetic stuff we talked about, all the different websites through Vassar have a lot of information, and we really appreciate Unite for Her, Him, Them's partnership with us as we build it out more, to really help our men with breast cancer.
Yeah, thank you. Please send them our way too. That Unite for Him program is incredible. And we want to see more men in our program.
Yes,
yeah,
definitely.
For sure. All right.
Thank you so much. And sorry.
Thank you.
Yeah, thank you so much. And thanks everyone for sharing your stories. It's always so great to hear.
Yeah, I agree. That was a good one. Another good one. Yeah.
Mahalo, everybody. Have a good day.
Thank you.
You
Bye-bye.
too.
So Erin, I feel like that's a wrap, right? Our June speaker series is over and
That was
done.
a good one.
That was a good
Yeah.
one. Yeah, a lot of incredible information, and just so appreciate Guy being able to be that voice, because it is rare. As much as we, try and talk about it a lot, we have his breast cancer. We have a lot of organizations out there that are doing remarkable work. It gets a little bit difficult, and the only way it's going to change that stigma is for more people talking about it. So
Absolutely. Yep.
Yeah.
Absolutely. So we appreciate everyone's questions and chiming in and conversation, and definitely share this video with friends and family and those that can benefit from having this knowledge. This is important for all of us to know. So we are so grateful for everyone being here. And of course, as we are wrapping up, I want to make sure that we give one final thanks to our sponsors, because they really help us continue to drive these conversations forward. So our digital education event this evening is presented by West, Merck, and Daiichi Sankyo, with additional support from GSK, Lilly, Gilead Sciences, and Immunogen. And hopefully we will see you next week as well for our virtual hangout, summer sips, cooking, some mixology that we'll be doing together. So that will be Wednesday, the 12th at 5 p.m. Eastern time. So get your happy hour ready.